Hello everyone. In today's lecture we are going to talk about anti-dysrhythmic and emergency drugs that we use to treat patients with chronic, acute, critical, and mental health care needs. One of the most common acronyms that we use when treating patients with cardiac emergencies such as chest pain, angina, and myocardial infarction is known as MONA. MONA stands for morphine, oxygen, nitroglycerin, and aspirin. Morphine is a narcotic opiate analgesic used to treat chest pain, MIs, and pulmonary edema because it not only relieves pain, but it helps dilate venous blood vessels and reduces the workload of the heart. Average dose ordered for morphine can be from 1 to 4 milligrams. We usually give it IV push over 1 to 5 minutes depending on the dose, and you may repeat it 5 to 30 minutes later as ordered by your physician. Important side effects to monitor for that morphine causes is respiratory depression and hypotension. So you want to make sure that you assess your patient's respiratory status quite frequently as well as monitor that blood pressure. Our main goal with oxygenation is to maintain an O2 sat above 94%. Oxygen is classified as a drug. Adequate oxygenation is necessary when we're treating chest pain, cardiac dysrhythmias, bradycardia, and pulmonary disorders because our patient is having an issue where they're not having enough oxygenation. Oxygen can also be a potent vasodilator, so it's very helpful when we're treating heart failure patients. Nitroglycerin is commonly used to treat angina pectoris and myocardial infarctions because it dilates our coronary arteries and improves blood flow to the heart. Remember, if we improve blood flow to the heart, then we can improve our cardiac output. It may also be used in patients that have congestive heart failure, especially with pulmonary edema, because it decreases preload and afterload. And remember, preload is the amount of blood that gets loaded into the heart before it's ejected out. Afterload is the amount of pressure that the heart has to overcome to eject the blood out, as well as the amount of blood that is left. So in your patients with congestive heart failure, especially with pulmonary edema, we don't want to leave a whole lot left in there because then it's going to back up and cause pulmonary congestion. Nitroglycerin can be given in several different forms. It may be given sublingually, translingual, oral, topical, and even IV. Usual sublingual dose is about 0.4 milligrams. It's going to go underneath the tongue, and we want to tell our patients to make sure they leave it there until it dissolves. Translingual is usually in a spray bottle, so they get just one spray as one dose. Some doses are oral where they just swallow it like they normally would a pill. And then we have something that's called nitropase where we put it on topically onto their skin and absorbs that way. Most patients that are experiencing continuous unstable angina as well as MIs are going to most likely be on IV nitroglycerin. We usually start that dose out low at about 5 mics, and you can increase it every 10 to 15 minutes until you reach where they are no longer pain-free or their pressure has become more stabilized. The big thing we want to assess for with patients that we're giving nitroglycerin to is whether or not they take erectile dysfunction drugs at home. These drugs end in the word fill. And we want to make sure we not only ask our male patients, but our female patients, because sometimes physicians order these medications for patients that have pulmonary hypertension. So make sure and ask all patients. If nitroglycerin is given with patients that are currently taking the erectile dysfunction drugs that end in fill, it can cause profound hypotension, and we can really drop their blood pressure out. Aspirin is another great drug that we like to use. It's a first-line emergency drug because it decreases platelet aggregation. So remember, especially in patients that are having a myocardial infarction, they've got an obstruction or a clotting or a thrombus somewhere up in those coronary arteries. So aspirin helps decrease that clotting part that's being caused by the platelets. We like to use it in management of acute coronary syndromes as well as the MI. Average dose is around 160 to 325 milligrams oral. If your patient has come in to the emergency department or they're on a unit and they start having this sudden onset of chest pain, we want to make sure that we have them chew the medication because it kind of helps speed up absorption. It can be given rectal suppository if your patient is unable to swallow or if they're having issues with nausea and vomiting. It's important to remember that aspirin is contraindicated if they've got a drug allergy to it or if they have a history of GI bleed or cerebral hemorrhage. Atropine is used primarily to treat symptomatic bradycardia. And when we talk about symptomatic bradycardia, some of the symptoms we may see when we assess our patient is they may have altered mental status, their heart rate will be below 60, their blood pressure may be hypotensive, their skin will be pale and clammy, signs that they've got decreased cardiac output and decreased tissue perfusion. Atropine increases heart rate because it inhibits actions of the vagus nerve, so it causes a parasympathetic effect. It may also be used to reverse organophosphate poisoning that are found in pesticides and nerve agents. Usual dose of atropine is 0.5 milligrams IV push, and it can usually be repeated up until where you have a maximum amount of 3 milligrams given total. It can be given IO through an intraosseous needle or through an ET tube as a last resort and emergency if you do not have IV access. Some of the side effects you'll see with atropine are tachycardia. Your patient may become restless or anxious. They may complain of feeling thirsty as well as urinary retention. So it's very important to check their urinary output to make sure they don't have any urinary retention. We want to do continuous hemodynamic monitoring, such as our heart rate, our blood pressure, and our cardiac rhythm, because we want to know as well if our atropine is being effective and they're not experiencing any cardiac dysrhythmias. Adenosine is a first choice treatment for SVT, known as supraventricular tachycardia, because it slows impulse conduction in the AV node. So it interrupts that reentry pathway and kind of creates that short period of asystole. It must be given rapid IV push because it's got a half-life of 5 seconds. So we want to make sure we give it through a large bore IV. We want to give it through an IV that's closest to make its pathway to the heart, as well as we want to follow it by a bolus or a normal saline flush. So sometimes it's a two-person job. One person to push the med, one person to push behind with the bolus so that we get it to the heart before the 5 seconds. Some of the side effects you may see with adenosine is it can cause ventricular atrophy. It can cause some short periods of bradycardia. It may make your patient feel flushed. They may complain of chest pain and they may have some shortness of breath. So it's really important that we do continuous cardiac monitoring when we're giving this medication. They need to be hooked up to the cardiac monitor. We want to assess their vital signs quite frequently, and you want to educate your patient before you give the med. Let them know how it might make them feel. Let them know what the purpose of it is so that they don't feel kind of scared when it happens. It is contraindicated if the SVT is caused from some other type of drug-related issue, such as an overdose or poisoning. We don't want to give it to patients that have sick sinus syndrome or that have second or third degree heart blocks. Amiodarone is a first-line drug used to treat life-threatening ventricular dysrhythmias such as VFib and VTAC. It acts on our sodium, potassium, and calcium channels. It also has alpha and beta adrenergic blocking effects. And when we think about alpha and beta, we have alpha 1 and alpha 2, and we have beta 1 and beta 2. Alpha 1 is a potent vasoconstrictor. Alpha 2 is more of a coronary artery vasoconstrictor. Beta 1 focuses strictly on our heart, so it works on our heart's automaticity as well as the contractions and the conductions of it, so it affects our heart rate and blood pressure. And beta 2 is a bronchodilator. Amiodarone may also be used to treat stable or unstable VTAC as well as atrial fibrillation. Dosing is different between cardiac arrest, patients without a pulse versus with a pulse. If our patient is in cardiac arrest, we give 300 milligrams IV push, and we can repeat that dose with 150 milligrams IV push. If our patient has a pulse, then we give 150 milligrams in an IV piggyback over 10 minutes, and then it's followed by a continuous IV infusion, usually over the next 24 hours. Some side effects that we want to watch for is hypotension and bradycardia. We want to monitor our heart rhythm as well as our blood pressure and our heart rate. Diltiazem is a calcium channel blocker often used to treat SVT, atrial fibrillation, and atrial flutter. It has a strong negative chronotropic effect to it, so it's very good in controlling a rapid heart rate. Usual bolus dose is 0.25 milligrams per kilo. We give that IV push over 2 minutes, followed by a continuous IV infusion. And usually the dose range is between 5 to 15 milligrams a minute, and we titrate that to what our heart rate is doing and what our goal is for our heart rate. Side effects to watch for is hypotension, bradycardia, and heart block. And we want to make sure we want to monitor our cardiac rhythm, and we assess our blood pressure and heart rate frequently. Diltiazem is contraindicated in patients that have heart failure, heart block, history of sick sinus syndrome, or Wolff-Parkinson-White syndrome. Lidocaine is used to treat ventricular dysrhythmias such as VTach, VFib, and frequent PVCs. Remember, PVCs are that premature ventricular contractions. It may also be used as an alternate to amiodarone because it decreases myocardial irritability. A usual dose is 1 to 1.5 milligrams per kilo IV bolus, followed by a continuous infusion of 1 to 4 milligrams a minute. We want to make sure that we have continuous cardiac monitoring, and we want to assess for signs of lidocaine toxicity. So you want to make sure that you assess your patient for symptoms of confusion, drowsiness, seizures, hearing impairment, and muscle twitching, more focused on a lot of neuro symptoms. It is contraindicated in patients that have liver impairment, heart failure, and if they are in some form of shock, they are a high risk for toxicity. Procainamide is an antidysrhythmia that we use a lot for ventricular tachycardia, SVT, and PVCs. They get a loading dose of 20 to 50 milligrams a minute, followed by a continuous infusion of 1 to 4 milligrams a minute. Side effects that we want to monitor for are hypotension, heart block, and rhythm disturbances. So we want to make sure that we monitor their cardiac rhythm, we assess our heart rate and blood pressure frequently, and we want to look for any ECG changes such as widening of that QRS complex. Procainamide is contraindicated in patients that may be in torsades de pointes. Vasopressin is used to treat ventricular fibrillation that is refractory to defibrillation. And what that means is we have a patient that is in cardiac arrest. They may be in VFib on the monitor. We've attempted to defibrillate them, but we've not been successful. We can give them a dose of vasopressin. It is an antidiuretic hormone produced in the body, and it allows a non-adrenergic peripheral vasoconstrictive effect. It increases coronary artery perfusion, and it has a vasopressor effect that is helpful in patients in cardiac arrest. It's a single dose. We give 40 units IV push during cardiac arrest, and it has to be in exchange for the first or second dose of epi. For patients that are experiencing severe hypotension, it may be ordered as a continuous IV infusion. Epinephrine is used in emergency cardiac situations. These patients may be in asystole, pulseless VTach, VFib. They may have severe bradycardia as well as hypotension. It has both alpha and beta adrenergic effects, so it improves perfusion to the heart and the brain through vasoconstriction. It also increases our chance of successfully defibrillating a patient in VFib or VTach. It's given in a 1 to 10,000 solution. It's 1 milligram IV push in cardiac arrest patient. And there's another concentration it'll come in. It'll come in a 1 to 1,000 concentration. It's usually in a small glass vial. And we give that in a dose, IM or sub-Q injections, that's commonly given to patients that are having anaphylactic reactions or asthma exacerbations. It may be given continuous IV infusion for patients that are experiencing severe bradycardia and hypotension, and we usually titrate the dose between 2 to 10 mics a minute. Magnesium is an essential function of our sodium, potassium, and adenosine triphosphate pump. It is usually hypomagnesemia is associated with atrial and ventricular dysrhythmias. It may be given in an emergency situation such as VTAC, VFib. Our patient may be experiencing dysrhythmias from digitalis toxicity, or they may just have hypomagnesemia. It is a drug of choice for torsades de pointes, and the dose is usually 1 to 2 grams given IV, and we give it over 5 to 20 minutes. Sodium bicarb is used to treat metabolic acidosis. It is not a first-line drug in cardiac arrest. However, if our patient has been resuscitated for a prolonged period of time, it may be ordered to be given because our patient is suspected of being acidotic. Administration is usually based on our ABG results on how severe acidotic our patient may be. Dose is 1 milliequivalent per kilo IV push. Any other dosage depends on our ABG analysis on what that pH is going to be. It may also be ordered continuous IV infusion for patients that are experiencing severe acidosis. Mannitol is an osmotic diuretic used to treat cerebral edema because it inhibits reabsorption of electrolytes and water. It's good to use in reducing increased intracranial pressure as well as preventing intracranial hypertension, cerebral edema that is caused by head trauma, some form of neurosurgery, or malignancy. Dosage is usually 1 gram per kilo IV bolus, and it comes in a 20 or 25% solution. We must use a filter needle if we're drawing it out and giving it, or we place a filter onto the IV tubing if it's a continuous IV piggyback. We want to make sure we assess our neurostatus, document accurate intake and output, and monitor lab studies such as our sodium and serum osmolality. Sodium is our big electrolyte that's lost with mannitol, so we want to make sure we watch our sodium levels. Serum osmolality is the measurement of dissolved particles per unit of water in serum, so it really tells us what the hydration status of our cells is. A normal range of serum osmolality would be between 270 to 300. A low level suggests that we have a high amount of water in our serum, so it kind of says that we're overhydrated and we've got some edema. A high level of serum osmolality kind of suggests that we have a deficient fluid volume and we are dehydrated. So we want to make sure we hold mannitol if that serum osmolality is over that 310 or 320 because our patient is already showing signs of dehydration. We don't want to pull any more fluid out of them. One of the most common emergency drugs that we use for poisoning or overdose is naloxone, otherwise known as Narcan. Naloxone is an opiate antagonist that reverses the effects of opiate drugs such as morphine, meperidine, codeine, and heroin, and it works by binding to opiate receptor sites within the system. It is indicated for overdose of opiate drugs, as well as patients that may be experiencing respiratory or cardiac depression from therapeutic doses that they may have received in the healthcare setting. It's 0.4 milligrams to 2 milligrams IV push. It may be given every 2 minutes until we reach the desired effect, such as our altered mental status is improved, our respiratory status is improved, our blood pressure is better, our heart rate's back to normal. We can give a maximum amount total of 10 milligrams. It may be given IM, IV, or IO, as well as your patient may be on a continuous IV infusion. We want to monitor for recurrent respiratory or cardiac depression after we've given it because it does have a short half-life. So your patient may have gotten better and then they may get back into some trouble again. We want to monitor for withdrawal symptoms such as nausea and vomiting, sweating, tremors, tachycardia, and hypertension. It also places our patient at risk for seizures, so we want to make sure we put our patient on seizure precautions. Flumazenil is a reversal agent used for treatment of overdose or poisoning of benzodiazepine medications such as diazepam or midazolam. It is indicated in patients that are having respiratory depression or severe sedation that is causing an airway compromise. The initial dose is 0.2 milligrams. We give it IV push, and they can follow by a second dose of 0.3 milligrams and a third as 0.5. It can be given every minute up to a maximum of 3 milligrams. We want to make sure we monitor our respiratory rate, our blood pressure, and mental status to see if we're improving. We also want to assess our patient for benzodiazepine withdrawal symptoms. Patients that have a history of seizures, flumazenil decreases their seizure threshold, so it can cause them to have seizures. These patients need to be on seizure precautions. Activated charcoal is used in treatment of poisoning or overdose by preventing absorption of toxins in the body by bonding to them in the GI tract. We give 1 to 2 grams per kilo up to 60 grams per dose. It should be administered within 30 minutes to 1 hour ingestion, so it's really important to ask your patient if they're able to tell you when they took the medication. We want to make sure we monitor a gag reflex. Some patients that have taken medications that cause sedative effects may not have the ability to swallow effectively. We want to assess their mental status as well as nausea and vomiting, and we want to maintain their airway. Our activated charcoal can be given orally or through a gastric tube. It's very thick, so it's important to make sure you flush behind the gastric tube. And we want to educate our patients in that activated charcoal is supposed to cause vomiting as well as black stools so that they are aware and not alarmed. We're going to talk about some drugs that we use for the treatment of shock. And one of those drugs that we commonly use is known as dopamine. Dopamine stimulates alpha, beta, and dopaminergic receptors, so it's very helpful in treating patients that have hypotension or bradycardia. It increases our cardiac output by increasing that myocardial contractility, putting that more squeeze on the heart, as well as increasing our heart rate. So it's kind of putting the focus on that beta 1 effect. It helps elevate our blood pressure by vasoconstriction through alpha 1. And when we give dopamine, we usually give it in 3 different levels of dosing. We have low dose, moderate dose, and high dose. So it's really important to know what's going on with your patient as well as what the goal is so that you know what dose you're going to be looking at. Low dose is known as the renal dose. It has dopaminergic effects that cause renal and mesenteric vasodilation. So it increases renal perfusion as well as perfusion to our GI tract. Moderate dose is 5 to 15 mics, so it increases our myocardial contraction, so it increases our cardiac output. And high dose is 15 mics to 20 mics, so it also causes that vasoconstriction, but it increases our heart rate fairly significantly, so it can increase our stroke volume and increase our cardiac output. It's important to assess that IV site every hour because infiltration of dopamine can cause tissue necrosis and can be harmful to our patient. Another drug used to treat shock is known as dobutamine. Dobutamine works primarily on the beta 1 receptor by increasing the force of myocardial contractility, so it has a positive inotropic effect as well as increasing our heart rate. It elevates our blood pressure by increasing our cardiac output. So the more that we're putting out, the better our pressure is going to be. It's used in treatment of heart failure or cardiogenic shock. And your standard dosage range will be between 2 to 20 mics per kilo a minute. We want to watch for side effects such as tachycardia. It can cause headaches, nausea, and vomiting. Our patient may have tremors as well as cardiac dysrhythmias. So it's real important that we have continuous cardiac monitoring. We assess our blood pressure frequently. We maintain eyes intake and output, as well as monitor for early signs of myocardial ischemia, such as chest pain or dysrhythmias. Albuterol is a medication often used to treat patients in anaphylactic shock, asthma, or COPD exacerbations. It's a beta-adrenergic bronchodilator used that reverses bronchial constriction. It's usually given in a dose of 0.5 ml solution that we give, and it'd be a nebulizer as an updraft treatment. or it may be given as a meter dose inhaler. Your patient may refer to this as their rescue inhaler. We want to make sure we assess breath sounds before and after treatment, as well as monitor our patient's respiratory status. And remember, wheezing can be a good thing. Sudden disappearance of wheezing suggests that our patient may be having bronchial spasms with no air exchange at all. We want to watch for side effects such as tachycardia. Your patient may have tremors or feel nervous, as well as they may experience cardiac dysrhythmias. Diphenhydramine is an antihistamine often used to block the histamine response in patients that may be in anaphylactic shock. It treats histamine-induced tissue swelling and pruritus. It's given 1 to 2 milligrams per kilo, usually between 25 to 50 milligrams. We can give it slow IV push. If we don't have IV access, we can give it deep IM. We may also give it with ranitidine, which is another histamine receptor blocker. So sometimes using these meds together in conjunction seems to be more effective. We want to monitor for side effects of diphenhydramine, such as drowsiness, sedation. It can cause hypotension as well as GI disturbances. D50 is a medication commonly used to treat hypoglycemia or insulin shock. It comes in a 50 ml vial. We usually give 1 vial IV push. It is highly irritating to veins, so it's important that we administer through a large bore IV. We want to assess the patency of our IV first, because if it does infiltrate, it can cause tissue necrosis or phlebitis. We want to make sure we monitor blood glucose before and after administration, as well as our urinary output, because D50 can cause some osmotic diuresis, so our output might increase. Glucagon is a hormone produced by the pancreas that increases blood glucose by stimulating the glycogen breakdown, so it can be used as a substitute if D50 is not available. We can use glucagon to treat hypoglycemia or insulin shock, and it may also be given to treat calcium channel blocker or beta blocker overdoses. If we're treating for hypoglycemia or insulin shock, the dose is 0.5 milligrams to 1 milligram, and it may be given IM, IV, or sub-Q. If we're treating calcium channel blocker or beta blocker overdoses, the dose is going to be higher, where we give 5 to 10 milligrams IV push. Some side effects to monitor for is it can cause hyperglycemia as well as nausea and vomiting. So it's important that we monitor our blood glucose to see if we've got the response that we need. Epinephrine is also a drug that is used in the first line treatment for anaphylactic shock. It has that beta-2 effect where it'll help dilate our airways through bronchial dilation. It promotes vasoconstriction and increases myocontractility through beta-1, and it inhibits further release of biochemical mediators causing the anaphylactic reaction. Dose depends on whether or not our patient is having mild symptoms versus severe symptoms with hypotension. If our patient is just having mild symptoms, then we can give 0.2 to 0.5 of that 1 to 1,000 concentration IM into the anterior lateral thigh, and we can give this dose every 5 to 15 minutes until symptoms have resolved. If our patient is having severe symptoms such as airway compromise as with hypotension, then our patient's going to get the epinephrine 0.05 to 0.1 milligram of a 1 to 10,000 solution that we give over 5 minutes. Our patient may require continuous infusion of epinephrine, and if so, then we can titrate that through a dose of 1 to 15 mics a minute. Norepinephrine is used to treat different types of shock, but it's most commonly used in septic shock because it stimulates alpha and beta 1 receptors, which makes it an extremely potent vasoconstrictor. If we're giving it in a low dose, it's going to increase our contractility as well as increase our systemic vascular resistance, allowing for our body to increase its cardiac output. In a high dose, it increases that alpha vasoconstriction as well as increasing our heart rate and our systemic vascular resistance. So in a way, it can kind of be a little harmful because it can decrease our cardiac output. Dose is 0.5 to 35 mics a minute, continuous IV infusion. We want to continuously monitor our cardiac rhythm as well as our heart rate and blood pressure. And we want to make sure when we start tapering this infusion that we taper it slowly, because if we discontinue it abruptly, it can cause our patient to have rebound severe hypotension. Now we are going to talk about drugs used to treat hypertensive crisis and pulmonary edema. One of those drugs is known as nitroprusside. Nitroprusside has a direct effect on our arterial and venous vasodilation, making it very effective in treating patients that are experiencing a hypertensive emergency. We also use it in patients that are in heart failure because it's effective in reducing afterload. Our dose range is 0.25 to 5 mics per kilo a minute with a max dose of 10 mics. And because it's a pretty potent vasodilator, we want to make sure that when we are titrating our dose, that we titrate it in small increments so that we don't create a severe hypertensive issue with our patients. This medication can't be exposed to light, so we want to make sure that we keep the IV bag or bottle in aluminum foil, or sometimes pharmacy will send up a brown bag with it to cover over the medication. If the solution appears brown or blue discolored, we want to make sure that we just throw it out. We taper this IV drip slowly because sudden discontinuation can cause an immediate hypotensive response. And if our patient is on this for a prolonged period of time, it increases risk for toxicity. So we want to make sure we monitor for symptoms of toxicity such as metabolic acidosis, profound hypotension, dyspnea, dizziness, as well as vomiting. Labetalol is another medication that we use to treat patients that are experiencing hypertensive crisis, as well as managing the blood pressure of a patient that has had a recent CVA. It has alpha and beta adrenergic blocking response, so it inhibits the sympathetic nervous system, causing our patient to have a decrease in heart rate. We'll have a decrease in blood pressure as well as myocardial contractility. It also decreases our myocardial oxygen consumption. So the overall goal is that labetalol makes less work on our heart. Labetalol can also reduce vasoconstriction from the CNS stimulation that helps manage our blood pressure as well. Dose can be 10 to 20 milligrams IV push over 2 minutes. Your patient may be on a continuous IV infusion with a max dose of 300 milligrams total. We want to monitor for side effects such as hypotension, bradycardia, and ventricular dysrhythmias. We also want to monitor for bronchial spasms because it has a beta 1 and a beta 2 effect. So if it's going to block beta 2, which is our bronchial dilator response, it can cause our patients in COPD or asthma to be at risk for bronchial spasms. We want to continuously monitor our cardiac rhythm as well as our heart rate and blood pressure. And it is contraindicated in patients that are experiencing heart failure, bradycardia, or patients that have COPD and asthma. Furosemide is a common medication that we give to patients that are experiencing heart failure and pulmonary edema. It's a loop diuretic that acts by inhibiting sodium and chloride reabsorption. It promotes renal excretion of water, sodium, and chloride, as well as depletes potassium. It can cause hypotension because of its vasodilative effects on our peripheral and renal system. If a patient is getting furosemide for the first initial time, the dosage is usually between 0.5 to 1 milligram per kilo IV push, given over 2 minutes. If they have been on furosemide for a period of time, then they're usually giving a higher dose of 2 milligrams per kilo. We want to make sure we assess our breath sounds before and after, as well as our blood pressure. We want to keep accurate intake and output, as well as monitor our labs with our electrolytes, especially our potassium and our BUN and our creatinine. Side effects that we want to watch for are hypovolemia, electrolyte disturbances such as potassium, and we want to use with caution in patients that have sulfonamide sensitivity because they are at risk for having an allergic reaction with the furosemide. We like to use morphine in patients that have pulmonary edema because it produces venous vasodilation. It allows for us to have a decrease in cardiac preload, which is that less blood filled into the ventricles. So less blood filled into the ventricles means less blood that can back up and cause venous congestion. Digoxin is a common cardiac glycoside drug that we use to treat patients with heart failure as well as atrial fib and atrial flutter. It's effective in heart failure because it increases our myocardial contraction and increasing our stroke volume, allowing an increase in our cardiac output. We like to use it to treat atrial fib and atrial flutter because it decreases heart rate as well as the conduction of our heart cells. An initial dose is 0.5 to 1 milligrams with a maintenance dose of 0.125 to 0.5 milligrams. It may be given oral or IV push, and if we give it IV push, it's important that we push it over 5 minutes. Hypokalemia can increase our patient's risk for digoxin toxicity by increasing the effects of digoxin on the myocardial cells, so it's important that we monitor our potassium levels. Dig toxicity signs and symptoms include diarrhea, nausea and vomiting, bradycardia. They may have some visual illusions such as halos around objects, confusion, and we want to make sure we monitor them for PVCs and cardiac dysrhythmias. If our patient is experiencing dig toxicity, we can give them something called Digibind, which is the antidote, and it binds to the molecules and excretes the digoxin out by the urine. We want to monitor our patient's cardiac rhythm before and after administration, especially if we're giving IV push. Always check the heart rate before administration. If it's 60 or less, we want to contact the MD before giving. We want to monitor for signs of digoxin toxicity, and we want to monitor our serum digoxin levels closely. Milrinone is a cardiac glycoside used as a short-term treatment of heart failure because it increases our myocardial contraction, resulting in an increase in stroke volume and cardiac output. It may be given to patients before heart transplant surgery. It helps promote vasodilation, therefore lowering our blood pressure. Our patient may be given 50 mics per kilo over 10 minutes, followed by a continuous infusion. And we don't usually give this med any longer than 48 to 72 hours. We want to make sure that we monitor our heart rate, our blood pressure, and cardiac rhythms because milrinone may cause severe cardiac dysrhythmias. Neseritide is used to treat acute heart failure by promoting sodium loss, so it kind of helps pull fluid out. It promotes vasodilation, allowing for us to lower our blood pressure. It's given in an IV bolus of 2 mics per kilo, followed by a continuous infusion. And we want to make sure that we monitor our heart rate, our blood pressure, and our cardiac rhythm. Spironolactone is another drug that we use to treat patients with heart failure. It's a potassium-sparing diuretic. It blocks the production of aldosterone, resulting in decreased sodium and fluid retention. It helps promote or reverse cardiac remodeling. And cardiac remodeling is like the changing of the size and the shape of the ventricles once we've had a cardiac injury to the heart. So it goes back and tries to help improve the size and the shape of the ventricles to where we can get more squeeze on the heart from the muscle and have an improved in cardiac output. Its dose is 12.5 to 25 milligrams PO daily. Angiotensin converting enzyme inhibitors, otherwise known as ACE inhibitors, are used to treat patients with heart failure. These medications usually end with a fix of Spril. Blocks conversion of angiotensin 1 to angiotensin 2, allowing a decrease in our blood fluid volume. It also decreases the release of aldosterone, so we have a reduction in sodium and fluid retention. It results in vasodilation because we have a decrease in venous blood return to the heart, so we don't have as much filling in there. And then we have a decrease in preload because we have a decrease in filling, so we have a decreased oxygen demand on the heart. The primary side effect of ACE inhibitors is hypotension, and patients that are volume depleted are more of at risk of experiencing hypotension. We want to make sure that we monitor our blood pressure as well as our potassium levels because ACE inhibitors can increase our potassium levels in the bloodstream. We talked previously about nitroglycerin being used as an emergency cardiac drug. It's also very good as an anti-anginal drug because it's an arterial and venous vasodilator. So it improves venous blood circulation by decreasing our preload and the amount of demand of oxygen on our heart. So we can use it in the treatment of heart failure because it decreases cardiac filling pressure and workload, helps relieve some of that pulmonary congestion. And we can use it in the treatment of acute MI and angina because it dilates the coronary arteries, increasing the blood flow and the amount of oxygen to our cardiac muscle. Some various drug names that you might see nitroglycerin listed as or in the forms of is nitroglycerin, nitrostat, nitrobid, nitropatch, and isoboride. The dosage varies based on the form, whether it's given sublingual, translingual, orally, or IV infusion. The most common side effects are headache, hypotension, dizziness, weakness, and they may have some reflex tachycardia. Because remember, when we drop our blood pressure down and we become hypotensive, our body's first defense mechanism is to increase our heart rate, trying to increase our cardiac demand. We want to monitor our patient's blood pressure before and after each dose. If our systolic blood pressure is less than 100 or that diastolic pressure is less than 60, we want to make sure that we contact our physician prior to administration. And it's contraindicated in patients that are taking erectile dysfunction meds, and those usually end in the suffix of "fil." You may also see beta blockers used as an anti-anginal drug. They decrease the effect of the sympathetic nervous system by blocking catecholamines, epinephrine, and norepinephrine. And they're effective in treating angina pain because they decrease myocardial contractility as well as decreasing the heart rate and reducing the need for oxygen consumption, therefore decreasing the demand on the heart, treating angina pain. They can be cardioselective and non-cardioselective. If it's cardioselective, it's working on beta-1 adrenergic receptor only. Some of these drugs, such as atenolol and metoprolol, are cardioselective. Non-cardioselective, it means it's going to work on beta-1 and beta-2. And remember, beta-1 is a lot of the heart, but beta-2 is that bronchial dilation. So if we block that bronchial dilation, we want to be very careful to not give these meds such as propranolol and atenolol to patients that are COPD and asthma patients. We want to make sure that we monitor our blood pressure and heart rate before and after administration. And we want to monitor for side effects such as hypotension, bradycardia, and those bronchial spasms and those non-selective drugs. Calcium channel blockers are a great anti-anginal drug because they help relax coronary arteries and decrease the workload of the heart by reducing the influx of calcium, resulting in decreased myocardial contractility, our decreased need for oxygen, and our decreased afterload. Arterial vasodilation decreases our blood pressure, and that's where we have a dilation of peripheral and coronary arteries. Some of these drug names you might see, such as amlodipine, diltiazem, nicardipine, verapamil. Side effects you want to monitor for are hypotension, reflex tachycardia when we do experience hypotension. Your patient may complain of headaches, dizziness. They may have some skin flushing, and of course they may have that reflex tachycardia when they have a hypotensive response. We want to make sure we monitor our blood pressure as well as our serum liver enzymes and output because calcium channel blockers can cause changes in our liver and kidney functions. In the last part of this lecture, we're going to talk about some anti-dysrhythmic drugs that are in 4 different classes, classes 1 through 4. Class 1 is our sodium channel blockers, such as quinidine, procainamide, and lidocaine. These drugs are great for treating atrial and ventricular dysrhythmias as well as SVT because they decrease the influx of sodium ions in cardiac cells during repolarization, so it slows the conduction down and prolongs repolarization. It can also prolong refractory periods, so it decreases premature impulses. and it decreases the automaticity or excitability by slowing depolarization and decreasing the probability of dysrhythmias. So in a way, it just kind of works on slowing everything down and allowing for proper repolarization and depolarization. Dosage-wise, lidocaine and procainamide are given orally or IV infusion, and quinidine and propranolol are given orally only. Some side effects you want to watch for with quinidine is our patients can experience nausea, vomiting, diarrhea, but they can also have some hypotension. They can develop a heart block and experience neurological symptoms. With lidocaine, we want to watch for bradycardia and hypotension, as well as seizures, blurred vision, and they may experience some cardiovascular depression. Class 2 of the antidysrhythmic drugs is our beta-adrenergic blockers. We've talked about these before. They end in LOL. And they inhibit dysrhythmias by blocking those catecholamines of epinephrine and norepinephrine and reducing calcium entry. They can also depress depolarization as well as decrease automaticity and slow down that AV conduction. So they're great for treating supraventricular tachycardic rhythms such as SVT, atrial fib, and atrial flutter. We've talked about how they can be cardioselective versus non-cardioselective. So we want to make sure we monitor them for side effects such as hypotension, bradycardia, and bronchospasms on our non-selective drugs. And we want to avoid giving those to patients that have COPD and asthma. Class 3 drugs are really designed to target prolonging repolarization. So they slow the rate of repolarization and increase the amount of the refractory period. Two of these drugs are known as amiodarone and adenosine. Amiodarone is used in the emergency treatment of ventricular dysrhythmias such as VFib or VTAC, and they can be used in atrial dysrhythmias as well, such as atrial fibrillation, as well as VTAC with or without a pulse. If our patient is experiencing cardiac arrest, the dosage is 300 milligrams IV push followed by 150 milligrams IV push. And if our patient is in a dysrhythmia with a pulse, then we give it 150 milligrams IV piggyback over 10 minutes followed by a continuous infusion for 24 hours. Adenosine slows conduction through the AV node, causing a transient AV block. So we use it to convert SVT as well as facilitated diagnosis of rapid dysrhythmias. And what I mean by that is when you see your patient have that short period of asystole, when the rhythm starts to kind of regather itself, sometimes you can see the underlying rhythm that's causing the patient to go into SVT. Commonly, atrial fib is the culprit for this. Adenosine has a half-life of 10 seconds. We give it rapid IV push with that normal saline flush to follow, so it's kind of a two-man job. We want to make sure we give it through a large bore IV site. It needs to be higher up the peripheral as possible, especially in the antecubital area. And you want to educate your patient that they may feel strange when we administer this medication. Last, we have our class 4 antidysrhythmic drugs, which are calcium channel blockers. We've talked about them briefly as well. Calcium channel blockers block and slow the calcium through channels such as our sinus and AV nodes. They also decrease excitability and contractility of the myocardium. A couple of drugs that are pretty common are known as verapamil and diltiazem. Verapamil is good because it depresses the sinus and AV conduction, so it decreases our ventricular response. So you may see it more commonly used in SVT if we're trying to focus on getting an AV nodal reentry. It may be given orally or IV push. Diltiazem is commonly used to treat supraventricular dysrhythmias such as atrial fib and atrial flutter for heart rate control. It's usually given in an IV bolus followed by a continuous IV infusion. With calcium channel blockers, we want to make sure we avoid giving these medications to patients that have Wolff-Parkinson-White syndrome. And we want to monitor for common side effects such as hypotension, bradycardia, and nausea and vomiting. So we want to make sure that we have continuous cardiac monitoring as well as frequent assessment of our blood pressure and heart rate.